Good morning. My name is Don Null. I'm the medical director at the Newborn Intensive Care Unit at Primary Children's Hospital in Salt Lake City. And today we're going to talk about conventional ventilation. Conventional ventilation really started in the early 1970s. Some was done in the late 60s, but it is not a technique that has been used for a very long time in neonates, but we have progressed dramatically with our techniques for conventional ventilation. First of all, we'll go over some of the terminology because there's a lot of terminology used in it. IMV is intermittent mandatory ventilation. Most of the early ventilators were time-cycled pressure-limited devices. Our more recent ventilators are volume ventilators. SIMV is synchronized intermittent mandatory ventilation. Assist control is sort of SIMV with every breath supported. Pressure support is assist control with every breath supported, but with a little less support, not a full support. SAVI is synchronized assisted ventilation in infants, which is really basically assist control. And VAPS is ventilator or volume assured pressure support. And VGPS is volume guarantee pressure support. And those are just done by different companies. And VG is volume guarantee. And MMV is mandatory minute volume, which means that the ventilator calculates over a given time how much volume is going to be delivered, and you set how much you want delivered per minute, and then the volumes that are being delivered are adjusted to ensure that that occurs. Well, what really are the goals of respiratory support? The first goal should be that you want to achieve uniform inflation of the lung. Because if you're going to prevent lung injury, you do it by keeping the lung uniformly inflated so parts of the lung don't get overdistended and parts are not atelectatic. Because minimizing over and under inflation reduces the risk of volutrauma and what's called atelectatrauma. The other thing is when you have uniform lung inflation, you can minimize oxygen exposure and you can minimize oxidative stress and injury to the baby. And then the other part is early appropriate extubation. So we certainly want to get babies off the ventilator quickly, but if you get them off and the only thing that happens is the lung collapses and then you have to re-intubate them, then you are really going to produce injury to the lung. If you look at it, applying ventilatory support in the least traumatic way to the lung is best accomplished by doing it over the mid portion of the pressure volume curve. And in order to do that, you have to have the lung uniformly inflated. And the other thing that's important to remember is that the lung is most vulnerable to injury when you are trying to recruit the lung, because part of the lung is atelectatic and you can injure that from shear forces, and the other part of the lung is inflated and it must be overinflated in order to worsen the compliance so that you can open the non-compliant atelectatic lung. So how do you achieve lung recruitment? Well, one of the best ways is to increase the mean airway pressure. And how do you accomplish that? Well, you can accomplish that by raising the end expiratory pressure, the PEEP. You can increase the inspiratory time. You can increase the ventilator rate. You can increase the peak inspiratory pressure, or you can increase the tidal volume that's being delivered to the baby. From a ventilation standpoint, so now we're talking about carbon dioxide, not oxygen level. Again, you can increase pressure because that increases what we call delta P, so that you have a higher pressure above the end expiratory pressure, which means you're giving a bigger volume to the patient. Or if you're in a volume mode, you can increase the volume. Sometimes to be more lung protective, you would merely increase the rate so that you don't overstretch the lung by giving too big a volume. And if the lung is overexpanded, if you decrease the overinflation, you will ventilate better. And if the lung is atelectatic, by improving the lung inflation, you will then improve the ability to ventilate because you move the patient up to the mid portion of the pressure volume curve. Well, the first thing we'll talk about is what's called synchronized assisted ventilation. That can be SIMV, and what that means is that you set a rate. If you set the rate at 20, the patient will receive 20 assisted breaths that will be synchronized with the baby's respiratory effort. And then you can have SAVI or assist control, which means that every breath the baby takes will be synchronized, but every breath will be assisted. And your choice is dependent upon whether you believe the baby needs more frequent assisted breaths to keep the lung volume normal. The techniques are, some of the devices used abdominal motion to sense the synchrony. Others use esophageal pressure. The most common ones are airflow changes, so that one's looking at a sensor in the airway in front of the ET tube that senses a pressure change and then synchronizes based on that. You can also use impedance pneumography to synchronize breaths with. What are the advantages of synchronized ventilation? Well, one is believed to be decreased barotrauma because the patient is breathing always with the ventilator and not against it. And so with that, you would expect decreased air leak, decreased chronic lung disease, bronchopulmonary dysplasia. If you decrease lung injury, you can expect decreased ventilator time. And because you're not pushing pressures up high in the venous system of the patient, you can hopefully decrease intracranial hemorrhage because you're keeping blood flowing out of the brain. And this gives you a more consistent tidal volume delivery, so the lung tends to remain more normally inflated. Well, what are some of the disadvantages reported? Well, one is barotrauma, the fact that you are using a device, and particularly if you use assist control where every breath is supported, if you've chosen too high a volume, too high a pressure, you can overdistend and keep the lung overdistended and injure it. And once you do that, you can increase the risk of intracranial hemorrhage. So while that can be beneficial, it can also be detrimental with that technique.